As Emily mentioned, today is a little bit of a different type of session. So we're going to have an interactive session where we're all learning from one another. There was a survey sent out earlier on that asked what specific challenges you have encountered in your clinics. And those responses were kind of grouped together into some major themes. The themes for the breakout sessions are number one, simulation. So our plan here is to discuss the difficulties you may have encountered in your clinics related to simulation. What do you do when you don't have all the necessary information or the data that you do have doesn't match what you're seeing with the patient? The second breakout session will have a positioning and alignment theme, just expressing some different challenges that you've faced when you're positioning a patient for treatment, different immobilization devices, possible topics for making shifts and using some creative immobilization devices that you may have had to use, or if patients have mobility issues and things like that, that you have to get a little bit more creative when positioning them. The third theme is a lack of equipment. So making sure that you're able to ensure reproducibility in the face of lack of equipment, whether that's a technology gap, so something with the machine, or a gap with immobilization devices, reliable power source, imaging, things like that. It could be something permanent, or it could just be something that you're experiencing at a certain time because a piece of technology is down. The fourth breakout session will be around image matching. So challenges that you may have faced related to image matching, whether there's a challenge related to technology. Are you developing films? Are you getting good exposures, things like that, so you're able to visualize anatomy? Or is there something else that you're facing when you're doing these image matching protocols? The fifth breakout session is going to be around protocols. So whether your clinic is using protocols or checklists, which team members use those protocols in either treatment planning, physics, treatment delivery, which areas of your clinic might there be a need for more protocols and standardization, who writes these, things like that. And sixth, this was a big one, the volume of patients. So when you have a very high volume of patients, what systems can be put in place to help with that? How do you ensure that you're getting the most urgent patients through? How do you ensure that you're checking off all of the items that all of these patients need and nobody is waiting too long to get their treatment and everybody is getting the treatment that they need? So our first theme is around simulation. Discuss any difficulties you've encountered in your clinic related to simulation. What do you do when you don't have all the necessary information or the data does not match? So is there anyone for whom that was one of your answers on the survey, that you were having difficulty with simulation? Anybody who's had difficulty with simulation and wants to share how they resolved some of those challenges?
Yes, I'm Ephraim from Malawi. I have a question, but it's not specifically related to IMRT, but the radiotherapy in general. We don't have a radiation therapy yet, but we expect to start radiation therapy services in January. Now we are at the stage of developing the radiation therapy protocol, right away from the diagnostic up to the radiation therapy. What are the key areas that you can share with me to consider when we are developing this radiation therapy protocol? Or if you have any links that can help us, because Malawi is a resource limited setting. So this is my question. Thank you.
So if I'm understanding correctly, Ephraim's question was around when radiological technologists are moving from that role into a radiation therapist role and how to make that transition. I think that's what I understood from the question. So I'm not sure if anybody else has any experience with that particular role change, or has any guidance around what they've done in their clinic.
Ephraim, do you have protocols now, or are you wanting to build protocols?
We don't have, we want to build now.
Okay. So that's I think it's really important to standardize, and maybe we can chat with or maybe Emily, if you can chat with a couple of the educators. I think in particular Claire probably has access to share her protocols. I could even see if my center at UC Health can. I think that's probably the easiest starting point is just going to a center that has established protocols and seeing if you can, use those. And then you can always, it's easier to have a starting point at least, and then that will give you, soup implements, when do you use contrast, when not, and then start modifying that into your own practice. Another important thing is, and again, maybe one of us can share this, or you'd have to create it, but hopefully one of us can share it, is having some sort of standardized, typically it's some sort of document with drop-down menus where physicians can say, okay, I'm going to be doing a head and neck plan. I want X, Y, and Z on that simulation, and it's just drop downs for the physician. So I think we can get that information for you. One other thing, which is really important, and I'm going to actually, Claire Monk, I think you should know it. What is that? Can you give Emily the link for the Australian website that has all that amazing information, site by site, disease specific, and setup notes?
Yep. Perhaps you're talking about EviQ?
That's the one. It's amazing.
I can try and find it online while we chat, and I can paste it into the chat as we go along.
Okay.
It has
great.
whole range of information on site specific stuff that's got vast quantities of information, both for radiation oncology and then other fields of oncology as well. So I'll pop that in now.
Yeah, and so this is something that Claire Dempsey, who works with Claire Monk, said that they use constantly in their clinic. So maybe once we get it, we can pull up a quick screen share and just take 1 minute to walk through it. It's a really helpful site for establishing, established or establishing radiation oncology centers.
Would you like me to do that now?
Sure, if you can.
Sure. It's my first time doing share screen on Zoom, so here we go. It's exciting for everyone. Hopefully you can see a screen which is predominantly purple. Have I done it correct?
Yep, we can see it. Thanks, Claire.
Okay. So as you can see, this is EviQ. It's quite a good source of information for us, created by the New South Wales government, which is the state that I'm based in Australia. So it's a reputable source. Most of the time I've spent on the site has been looking at the radiation oncology tab. And as you can see here, it's site specific. So for example, let's go into head and neck. And then it breaks it down into different sites, different tumor types. So let's say you wanted to look at an oral cavity SCC, and you can click on this and it brings up all the information that's related just to oral cavity SCC external beam radiation therapy, including indications in your patient population, and then information on clinical information and what's involved there. Simulation procedures. So this could be very helpful, perhaps with Ephraim and the question about setting up protocols to come across from a radiography context to a radiotherapy context. It gives information on positioning suggestions, contrast requirements, bolus considerations, even just what imaging you're doing. Is it just CT? Is it CT and other imaging if it's available in your area, such as MRI or PET for each of these different sites? Information on dose prescriptions, target volumes, and what's involved for the RO in contouring, organs at risk, and a link to those. And then also information with suggestions on target verification. So what's an appropriate imaging procedure to follow for these patients. Do they need weekly imaging, daily imaging, if that's something that your centre can provide? And is KV planar imaging appropriate, or is cone beam imaging more beneficial for these patients, and so on. Also, information about side effects that patients can be perhaps getting for these sites as well. So it's just a wealth of information. And as you can see, that was just for oral cavity SCC. So if you have time, it's worth looking at just because of the wealth of information that's on there. I will now try and stop sharing.
Yep. Thanks so much, Claire. So maybe we'll just run through some of these questions real quickly on the right-hand side. So some of these we can do pretty quickly just to save time. Is there any reason why head and neck patients are treated first? Different cancers grow at different rates. And so in particular, things like, just as examples, there are others, but head and neck, cervical cancer are two examples of cancers that grow really quickly. And so we want to get those treated first, whereas typically cancers like breast and prostate are more slow growing and can be delayed, slightly more. So there's same thing with breaks. If you remember, discussions about breaks in treatment. If you have to choose who gets a break and who doesn't, then you would want to ensure that patients like cervix cancer or head and neck do not get a break when possible. So it just has to do with the type of disease. Good question.
A similar question, sorry, Adam, is also about that why breast cancer patients are treated after 6 weeks of surgery. Yep. Again, a timing-based thing. And my understanding, at least what I'm familiar with, is that's to do with healing post-surgery, waiting for any swelling that the patients may have experienced to settle, because it's not very helpful if you go ahead and do your CT sim when the patient's still having a lot of swelling after surgery, and then they come back for treatment and they might have a completely different contour, which obviously is going to affect all of your dose distribution, and all the calculations you've done then may not be valid.
Yep, perfect. Thank you. Thank you, Claire. If instructions are not clear or information does not match, simulation should not proceed until all is clear, or else you may subject patients to unnecessary resims. Maybe this is an answer to the earlier one. So maybe there are questions about just things not matching at simulation and treatment. I think that's somewhat normal to have, minor changes from, simulation. Typically, the doctor has a pretty good idea of what he or she wants, but lots of times that can change, right? So maybe the extent of the disease is better understood after the CT simulation. Again, some of it depends on if there is the possibility for diagnostic imaging information prior to your CT simulation in your radiation oncology clinic, and how long ago that was. So if you don't have access to good quality diagnostic information, then a lot of the staging, a lot of the workup from the physician standpoint will be after the CT simulation in your center. If there is good diagnostic imaging, but it was taken, 3 months ago, 4 months ago, even 1 month ago, and in quickly progressing tumors, that staging, that whole workup, and that decision by the radiation oncologist on how he or she will treat will change. And so the biggest thing is communication. And so I think we've mentioned this in previous lectures, that you really need to be on the same page. And so the job of the RTT, the dosimetrist, the physicist, they all work so closely together in the ultimate treatment. And so all three parties need to completely understand each other along each process. And so it's a little bit tough for me to say, as I think it's heavily center or department specific in how your department works. But the key point is that things will change, and two, to make sure that you have, really good communication. Any other thoughts, Jill or Claire? Okay.
I think you've covered it. There's a good question about during CT sim, simulated with contrast and non-contrast. During CT diagnostic, patients must have had contrast CT2. What exactly is the essence of doing another CT sim with contrast, since the planning isn't done with the contrast CT?
Okay. You want me to take this, or you want to take it?
If you have information to share, that would be wonderful.
Yeah. So typically we use contrast in order to help delineate either targets or organs at risk or both. And so it's an important tool to use in our CT simulation for different disease sites. So you just saw, for example, in the EviQ that Claire shared that for a lot of head and neck cancers you'll use contrast, and then for a lot of GU cancers, so gastric cancers, and you'll use oral contrast, and sometimes you use both. So really important for helping the physician, but it can have impacts on the treatment planning system. So the treatment planning system goes by what we call Hounsfield units. Hounsfield units are basically how dark or how bright a pixel is within the image, or an organ is within an image. And this will dictate how the radiation, photons or electrons, interact. And so if you've got contrast injected or contrast, oral contrast in the small bowel, then it will uptake, it will remove a lot more photons, for example, than if it weren't there. And so when you're treating the patient doesn't have oral contrast in for 5 weeks. It lasts for a matter of hours. And so you want to mimic how the patient will be treated with the initial simulation. So typically you'll do an initial simulation without contrast. That will be your planning CT, and then you'll have to administer the contrast, and that will be your more for diagnostic purposes. Again, if you don't have the option for both, or if the contrast has to be, sometimes oral contrast has to be ingested long before the simulation, then the other option is just to contour out the contrast and give a density override to something similar to that normal organ at risk.
I see Martin has his hand up.
Martin, if you can unmute yourself.
Oh, yes, thank you. I wanted to say a little bit on that point that you just talked about contrasted CT.
Yep, sure.
Actually, right now, the new systems, like Eclipse, there is no significant change whether you use a contrasted CT or non-contrasted CT, because it used to be thought of that when you give contrast, the density, the electron densities change, and the system uses electron density when it is doing its calculations. However, we do give contrast, like you've said, in some sites like head and neck and then pelvis, because we want to delineate the lymph nodes, and you cannot see the normal lymph nodes except if it is diseased. But we know that lymph nodes follow the vessels, the blood vessels. So when you give contrast, you are able to see the blood vessels, and then you contour the blood vessels with a margin. So that will be delineating the lymph nodes as well. But in some other sites like the breast, we don't give contrast. And then also, like in my center, we had started using only one series. That is a contrasted CT for both pelvic and head and necks. However, we realized that if the patient did not prepare well enough, for example, in pelvis for prostate and cervix, where you need to look at the bladder filling and the rectal emptying protocols, and then you just give contrast, you may end up repeating the examination and therefore wasting contrast. So we've decided that in such cases, we do both, that is post and pre-contrast. But when we are exporting to the system, we only export contrasted series.
Martin, excuse me, Martin, do you use density overrides on the contrast series?
No, we don't use. We had We had a team from WASHU, that is Tianyu, and then Dr. San. They said that there's some research which has been done, and it was found out that there is no significant difference between contrast and non-contrasted. So we don't, except where you have maybe like we in breast where we use catheters with contrast. There we do override.
Yeah, great. Well, Martin, thank you so much. That was a really great response. It was much better than my response, I'd have to say. So I appreciate the knowledge and the details. It's funny, I actually work with a physicist from WashU, and I think she said it's the same, that they didn't contour out the contrast.
Yeah.
And you are correct. In all honesty, it doesn't make much of a difference at all, especially, you know, in nowadays where VMAT is so robust in terms of planning. So the differences are really small. I've not personally done a study on those differences, and it's pretty easy for us to contour out. So we still do, but I definitely see the value and efficiency in not contouring it out. Again, there would still be a little bit of a judgment call there, I think, depending on, you know, if you're doing just you know, how much contrast there is, and how dense is the contrast.
Sure.
Proximity to something. If there, I could see that. I agree that the majority of the time it doesn't make much of a difference. Sometimes our dosimetrists leave it off, and we'll just do a quick recalc with it, and we'll say, okay, that really didn't change much. But there would still, I think, be some occasions where it would be a judgment call where maybe it would make a small impact where you would still want it done. But I agree with you that probably the majority of the cases, no. So thank you so much, Martin. That was a really nice answer for everyone on here.
You're welcome.
I had a few questions coming through about immobilization, I see, which ties into our next room, so to speak. Jill, are you happy if we start looking at the second point about positioning and alignment?
I was just going to go there. That's perfect.
Perfect. I'll hand over.
No, you go ahead if you had some in mind.
I was just going to throw it out there and say, would anyone like to kick us off with any challenges that they've faced positioning patients or working with particular immobilization?
So I'll pick one out that I thought was good. Around, it's not specifically immobilization devices, but how can one nicely position a bolus on a curved structure? What actions would you take if you have limited resources? So that kind of puts two of our themes together: limited resources and using different devices. So, you know, it'd be really nice if everybody was shaped like a square and we could apply bolus very uniformly to some of these curved structures. When I worked in CT Sim, we had to be pretty creative in some of the things that we used, you know, around the nose, in the ear, in the nose, things like that. Those are some pretty changing contours. So a lot of times we used wet gauze or gauze that was coated in Vaseline because you could get much more conformity if we weren't able to use something like a wax bolus. So typically we would do our best to do a wax bolus because that was, you know, you'd mold it right to the patient's face and that would be the same for every single treatment. But if we didn't have wax bolus, we would try with Vaseline gauze or wet towels, which I can appreciate from a reproducibility standpoint and a standardization standpoint. You know, if you're trying to emulate a half cm bolus, it's not exact. So doing the best you can with what you have always is good. With breast patients, if you're using the big sheet of Superflab, oftentimes if you have a patient that has a large changing contour or maybe the crease underneath the breast, it's difficult to fold the bolus in under there. We would use often a lot of tape to put almost like traction or pressure without compressing the bolus. So we didn't want to take a half cm bolus and or a 1 cm bolus and squish it down by using tape all over the patient, but To get into that contour, we often had to use multiple pieces of tape to get it to conform to the patient contour. Super important to have it in contact with the patient's skin so that there's not an air gap between the bolus and the patient's skin, because that can affect your dose absorption. Not sure if the others have had experiences there.
I was thinking similar things, Jill, in terms of using the wet gauze, as you were saying, or the Vaseline gauze or paraffin gauze as we use. It also ties in, I see, with the question from John about that bolus is best placed directly on the patient's skin. Considering transmission of infections, what's the standardized practice? So my thoughts on that were, if it is say a large sheet of bolus that you're able to use for lots of different patient setups because it's not been custom made, then even just wrapping it in what we would call Glad wrap or cling wrap, or that thin plastic food film, is a quick and easy way of doing that. If anyone has seen any other ways, but that's what I'm most familiar with.
Yeah, that's what we did in the clinic as well. And often they have they're almost sealed in like a thicker plastic wrapping, and then you wrap it in the plastic wrap. But we would always use like cleaning wipes after the fact to try to make sure that it was as clean as possible. It's not ideal, but had to do the best we could. Always personalized bolus was kept in its own location, so it's not rubbing up against another patient's bolus and potentially transferring ickies to someone else. Doing the best we can. It's not always easy, for sure.
It looks like Martin would also like to comment on this topic, so feel free to unmute yourself, Martin.
Okay, I have something to say concerning this topic. Can I go ahead?
Yes, please,
Yeah.
Victor.
All right. Now we have challenges during treating a vulvar case. Now what we do is we simulate these patients in frog view using a backlog. But over time, you get to see that the backlog starts deforming and losing shape. So it's become challenging to match during matching and to continue treating this patient. So I want to get your views on this kind of cases. What do you do with them? What kind of positioning do you assume for them to get treatment?
Specific to the backlock issue, that was something I experienced in the clinic as well. And it tended to be with the backlocks that had a more papery feeling than the initial ones that were very plastic feeling. And we would re-vacuum the backlocks once a week. So we would position the patient, and then we would use our in-room suction to suck out any air that had kind of seeped in. And we found that once a week was kind of the tipping point where we were able to, it wasn't yet affecting patient positioning, but we were able to keep that a rigid form. I'm not sure if there's a different form factor for how that was done, but we found that in-room suction was more than enough to take the air out in that case, once it had already been formed, of course, in CT sim.
That's a really good idea, Jill. Thanks for that. I think that should probably help a lot of people. I want to touch just on the vulvar patients as well. And this touches on, it's challenging. Reproducibility is challenging. Lots of times you get swelling, which poses challenges for alignment and matching. And the bolus is usually tough on these patients too. So you get sort of everything. And so one more thing on the bolus, which I think is helpful. One, as RTTs pay attention, you always do, but daily, and give that feedback and get the feedback from the physician or from the physicist on if there are any other, solutions that you can do. So as you heard from Jill and Claire, there are lots of, creative ways that you can use bolus. I think bolus is all about creativity, even to get, to compress parts of bolus into, little curves in places. You can put like, gauze, dry gauze, or something like that, and then ball it up and then tape it down, and it can push bolus into areas too. And if bolus isn't perfect, it's still okay. And to be honest with you, I don't know at what point that this transitions from okay to not okay, but you are still going to get, the whole idea of bolus is that your photons are interacting with the bolus, generating those forward scattered electrons, which then treat downstream. That downstream happens to be the surface of the skin. And so even if there is a little bit of an air gap, you're still going to be generating those electrons within the bolus, which are going to travel through the air and hit the patient's skin. So you're still going to get dose to the skin. So a little bit of gap is still okay, but we do want to minimize that gap as much as possible, like Jill and Claire said. The other thing about vulvar cases, and other similar cases, you can do some tricks on the planning end. So physicists or dosimetrists that are in the audience, a really important concept is creating flash. And so I think a lot of you all may be familiar with using flash to treat breast patients or 3D breast patients. Well, as you transition to VMAT and IMRT, you'll still create flash through a creative mechanism for those patients, even with VMAT. And you can do the same with other patients. So vulvar patients, all of our vulvar patients, we have flash built into our VMAT plan. So because those patients are difficult to set up, because they're swelling, you want to have that flexibility where if it's not perfectly within the original PTV, as long as it's within the flash structure, you'll still get coverage. And so, Emily, if you can remind me, I can email you out. We've got a pretty robust flash procedure for physics and dosimetry, and it explains what sites it would be used for and how you would do it. So I can send that to you, and you can send it to the group if that's all right.
Absolutely. I'm taking notes about the resources that we're sharing. So when we send an email recapping this session, we can include all of these things.
Okay, thanks.
So there's a question here that maybe kind of moves us into the image matching realm, as well as simulation. So there's a question around bladder preparation. For example, prostate cancer, how are you sure of the bladder volume when you instructed the patient to take a certain volume of fluid from the sim room and probably follow through the treatment room? How are you sure of the bladder volume, or what can you advise? So in my experience, and I'm sure that there are others that have something that they'd be happy to share as well. In my experience, we've always instructed the patients to drink a certain volume of water, and different patients have different feelings of bladder fullness. So some patients will feel full if they've taken a smaller volume of water, and some patients can drink tons and tons of water and never feel full. So we always wanted our patients to feel comfortably full, not like they were going to burst and have an accident on the treatment couch, but also that there was a feeling of pressure there. Ultimately, for us, the bladder filling is less about having a standard volume and more about having the bladder out of the way of your treatment field, right? So you want to have minimal bladder volume being treated when you're treating something like prostate cancer. It's not about having that exact same reproducibility every day. And that's where in a lot of cases, our image matching would come into play. So we would, and it would change also throughout the patient's treatment as they were starting to get some of those side effects that were affecting their bladder. We would cone beam CT them, see that their bladder was maybe not as full as we needed and it was drooping into the treatment field, and we would ask them to go drink more water. Not ideal to get a patient on the table with what they felt was a full bladder, scan them, and then send them back to the waiting room with a glass of water to continue drinking. But that was really honestly the best way, because that the volume that they're drinking, it doesn't necessarily translate to a feeling or a level of bladder fullness based on what they've drank through the day, their level of hydration. So it's unfortunately, I think there's no like magic answer for this one, but I'd be happy to hear if others have experiences here as well.
Emily, maybe you can remind me also to send. I've got a number of bladder, rectum, and prostate procedures I can send on. Just to note that they're sort of ultra complex from one of our doctors, so you can take it with a grain of salt, but it should help make some sense. And so just to elaborate a little bit more just on prostate specific. So we will do a cone beam CT every treatment, and we differentiate between two cases. So if we're doing traditional fractionation, 20 or more fractions for our prostates, then we have a specific guidelines for our bladder. So we want it about 2/3 full, but we won't stop treatment. So even if the bladder is a quarter full or the rectum is fully distended, we're not going to get the patient off the table and refill the bladder or empty the rectum. We're going to go ahead and treat. We'll make a note. We'll make sure that the physician's aware. We give instructions to the patient and we proceed, and we continue this process. And sometimes we have an escalation of where that information goes, just because one fraction out of 20 or so isn't as big of a deal. But if we're doing prostate SBRT, now that bladder filling becomes much more important and critical. And so if we have less than 2/3 bladder filling, we won't treat and we will get the patient off the table. You're talking 5 fractions now, and that has a big difference. So that bladder filling and rectal filling, it has two reasons for it. One is the organ dose itself, so the bladder dose, the rectum dose. So if there's a too empty of a bladder, you're going to get a lot more actual bladder dose. Same thing with rectum. If the rectum's too full, then you're going to get a lot more rectum dose. It's going to creep into the PTV. You can get fistulas or other things that we don't want. The other thing is actual prostate treatment. And so it can deform, if you've got a distended rectum or a difference in your bladder filling, it will actually change it could change the shape of the prostate. So it can squish it, squeeze it, change its shape. The seminal vesicles can be all over the place. And so it's really important. SBRT, you want to treat it, be very concerned with it. Non-SBRT, you want to make sure that your patient is aware for improvements on the next fraction, your staff is aware, and you continuously work on this process. But cone beam CT, I think, is a necessity.
I agree with those. Oh, sorry, Jill.
No, go ahead.
I agree with your comments and Adam's comments as well, that if I'm looking at an image each day and wondering what to do, I definitely look at the fractionation to decide how to proceed. If you don't do it already, it's definitely worthwhile chatting to the patient as you take them in the room each day to say, how's your bladder feeling? Have you had enough time for your water? Do you think you feel as full as you have on the other days? It's so activity dependent, as you mentioned, and weather dependent as to how hydrated they are. They can drink the same amount of water one day to the next, but some days their body just sucks it up and it just does not get down into the bladder. And I wish there was a gold perfect answer, and I wish I had $1 for every time I had to talk to a patient about their bladder and bowels for a prostate, because it is a tricky topic. If for some reason you didn't have access to cone beam, but you were doing KVs daily, I have also seen some people will look and try and see a bladder shadow on your AP KV. So that's another option as well.
And back to the origin, before we had the image matching abilities, we always just took an SSD, right? So you would take an SSD to the patient's pelvis, and you could tell, I mean, within reason, how full a patient's bladder was or empty if your SSD was within a range. It's not exact and it's not perfect, and certainly without image matching you wouldn't be doing highly conformal protocols, but it was often effective in telling if a patient needed to jump off the couch and go grab some more water or not. So that was the way we did it initially before we had image matching and we were just taking NV, like port film. So another effective way to do it. And there was a question in the chat as well about if anybody has bladder filling protocols to share that have worked well for them. So I'm going to leave that one to offline. If anybody has protocols to share and can get them back to the group, I think Emily can circulate those, if I'm not mistaken. Just because there's probably a lot of folks out there that have protocols that are effective in their centers that can share them. There was also a question about dose, and I'm assuming that this is a concern around dose for daily CBCT for children, especially head and neck and pelvis. So when we're doing pediatric patient treatment, are we cone-beam CT daily? Are we worried about the dose there? And what considerations have people taken to mitigate some of those concerns?
Let's see. So that's a really good question, and I want to make sure I'm honest that I have not worked with pediatrics, and so the pediatric question would probably be better answered by someone that has extensive experience with that. That being said, I think the idea is that radiation therapy is really high. They're really high doses, and they can be, they have curative intent if you hit the target, or they can have curative intent. But either way, palliative or curative, they're beneficial only if you hit the target, and your organs at risk can have really high toxicities if you're missing or if you're accidentally hitting organs at risk, whereas CBCTs have very little dose. And so, again, without having extensive experience working with pediatrics or small children, I think the reasoning is the same, that the most important thing is that we hit the tumor accurately and are not hitting organs at risk. And my feeling is, and always has been, that we do the necessary imaging to ensure that that happens. And so I would not worry about imaging dose if it has, critical importance on actual targeting of high doses from radiation therapy. Looks like there was another question earlier on, or a couple questions about maybe 4D CT.
So that one about patients who are not able to do the 4D CT, whether because of age or some other factors, and in one case actually falling asleep during the 4D, so it's hard to get a good breathing trace in that case, and how to manage that with the care team.
Yep. So these 4Ds, it's really important that again, that I think this communication between all parties is there. So from the simulation RTTs to the physician, to the dosimetrist, the physicist, the treating RTTs, and so everyone really having a good understanding. And so that's great if you see something like that and you make note of it and you can fix it. That's great, because if a patient falls asleep and they just have a big long 30-second exhale right when you're scanning over the moving lung tumor near the diaphragm, well, that's not going to be really helpful, because it's probably moving 1 to 2 cm, but you don't have any movement on the 4D CT. So really knowing what you're doing at all steps and its importance for everyone else is really good. So having those conversations with your team. So for example, we'll have our RTTs or our physicists in on a 4D CT, and we will take note, for example, of the breathing, but not only of the breathing, but where they are within the scan and how they're breathing. So if the scan is just perfect the whole time, but all of a sudden they have some terrible breathing right where you think, well, maybe we're right around the tumor, we'll probably redo that scan. And you can visualize it, on the the repeat, I mean, on the playback of the 4D CT, you know, you can see, okay, there's motion, you can see lots of motion here, but not motion here. That's right where we want to see the motion. So being vigilant of that. Anyone, Claire or Jill, do you have any follow-up?
I would say that this kind of dovetails nicely into the protocols discussion. I think it's really, really important that there's, you know, eligibility criteria for certain things. Not all patients are going to be suitable for everything, right? So there was another question about patients who have an inability to lay still or follow instructions and stuff like that. And I think having a protocol and standardization is wonderful, but there are people who are going to fall outside of that, you know, ideal gold standard way of doing things. And we have to have a basket to catch those people in so that they can get treated as well to the best of our ability. So while 4D CT might get us the best possible, you know, treatment plan and planning outcome for that patient, if it doesn't work, it doesn't work. And we need to have a protocol that meets the needs of those patients too, because I can think of lots of cases, not necessarily just age, but certainly people with decreased lung function, people with decreased cognitive ability, that it's going to be much more challenging for them to follow those instructions. So we need to have kind of eligibility criteria around that. And what to do if they don't meet those criteria, because then having to cobble together something really quickly can be a really big challenge for both the folks in CT Sim and treatment planning and stuff like that. So that lends itself really nicely to the protocol discussion and how you're going to define which patients are eligible for what.
Yep. And I'll just elaborate a little bit more, because this 4D CT I think is really important. And you know, I think all over the world, you know, sometimes the implications of different aspects of errors within the 4D CT workflow are not readily understood. And so one other thing, so it's directly tied into, the simulation is directly tied into treatment. Again, the critical importance of RTTs on both sides of this, and helping your dosimetrist and your physicist and your radiation oncologist understand this, right? You all see this and are treating. And so when you're treating a patient that was used 4D CT, there are different mechanisms for looking at, you know, how well does the treatment align to the simulation. And so different ways that this is done. So, you know, what anatomical site are we treating? Are there fiducials in place? You know, how you look at it. But as an example, so I'll go back to the lung example. And so if you're treating a lung, for example, and had a 4D CT, then what sort of verification do you have at the machine that you're breathing the same way, or that your GTV, your actual tumor, is within your ITV, hopefully, or at least within your PTV. And so different things that we do, for example, it depends on what sort of technology you have, but utilizing it to the best of your ability. You can take a regular CBCT, right, and make sure that the soft tissue lines up well, and that, you know, you'll have sort of a blur of your GTV within your lung, and that blur looks the same as the blur on your simulation 4D CT. If you've got 4D CBCT capabilities, you can use that. Some machines have that. Something as simple as fluoro. So I would assume that most LINACs nowadays have fluoro capabilities, and this is really strong. So if you put in your treatment plan a setup field, an AP and a lat or a PA, and some sort of oblique, just in case, you know, the imaging is obstructed by, say, a spine or something like that, where it's more difficult to see, you can put it in an oblique field. And if you can visualize with a fluoro, with two of those fields, or even one of them, just for a sanity check, and typically you can see the tumor, at least in one of those three fields, moving in the fluoro, and you want to see it moving within the ITV. Again, it's a pretty inexpensive cheap method. It should be available on most Linux. So you would just have to learn how to use it, but it's really good for visualizing. Okay, so if you had a bad 4D CT without much motion, then you go to treat, and all of a sudden you see this tumor, moving 5 millimeters outside of the PTV. That's a hard stop, and you say, okay, you know what? I can see this on treatment. Is there a way to limit the breathing motion more? Is our compression right, or what's going on, or why is this so different? If you can't, then you'd have to go back to the simulation. But the treating therapists, the simulation therapists, and everyone in between really needs to understand that process. And last thing, just because I think 4D-CT is so important, you can also coach. So a lot of people will coach, especially if a patient is falling asleep constantly. There are apps for it on your phone. You can just verbally coach, breathe in, breathe out, breathe in, and you have to get that timing right for each patient. But just to note also, if you do coach, typically the respiratory motion will be higher. So you'll have more motion with the coaching. So you might get a good pattern, but you might treat a little bit more healthy tissue. So just being cognizant of that.
If everybody is okay with it, I think we can move on to our last topic, because it was actually the most frequently mentioned topic in the survey, and that's volume of patients or quantity of patients. And the question that we can get started with is, what systems could be put in place to help with a very high volume of patients in your center? And throwing that out there, of course, to our educators and to the group. What challenges have you run into, or what solutions have you run into also?
So I've got a couple ideas. Sorry, I feel like I'm talking so much, but feel free to cut me off, Claire or Jill, if you ever want. So heavy throughput, this is really important. And so a lot of your all centers, I know, treat a lot of patients, and being able to get them in and out quickly is really important. So a number of different things that you can look at. So one is, and Jill and Claire can probably elaborate on this, but one way of increasing patient throughput is by grouping similar patients together. And so that way you're not constantly swapping out setup devices, changing things on your table, getting in a different mindset as a therapist. You do all of your breasts all together, and then you move to prostate, and then you move to head and neck, and then you move to brain, and you move to wherever, but you knock out all of your patients at a time in certain blocks. And so I do know that across the world, there are certain centers that treat this way, and they are able to, significantly increase their patient throughput just by that mechanism. Other things that we can do, so imaging. So imaging is a big topic on how often do we image which patients. And so, a lot of this can also come down to a judgment call from your radiation oncologist on, where does imaging become most significant and most important, and how can you cut down on imaging and still get good results? And so a lot of this goes into patient population and disease site. And so, imaging less on palliative patients where possible can be helpful in treating more patients throughout the day. And so, but you don't want to miss, right? So there's a difference, there's a key between the two. But even if you move from, instead of doing CBCTs, you do a quick MVKV and you're fine with that on certain patients, whereas other patients where you're treating with curative intent and you've got nodal involvement, and you've really got to line up things properly with soft tissue, and then you may have to do a CBCT every day on that patient. And so having this discussion with your radiation oncologist, again, the more imaging that you can cut down where not necessary, you can increase patient throughput. Other clever concepts. And so this may not be, again, for everyone, but, you know, thinking outside the box. So there's a company, Diacor, and they sell these setup devices. And I can't remember what it's, we've got the brachytherapy one, it's called a Zephyr board, but they've got a similar one, I think, for external beam. And, you know, what they've noticed is that the majority of their patients, you know, where a lot of time is spent setting up patients inside the room, you know, walking a patient in, walking a patient out, getting the patient dressed and all that sort of stuff that adds to treatment time. And so they came out with a concept where you've got a setup room outside of your vault, and they'll set up the patient on this treatment board, and with all the setup devices, it's an indexable board. It's an overlay that fits on top of your treatment table, and they'll put you in all the setup. They'll get you changed. They put you on the setup devices. They get you fully ready. When the other patient is done inside the room, that patient is put onto a gurney, and it's got a little air compressor. So you just press a little button, it becomes a little hoverboard. It's really nice. And so you just hover this patient, unlock from the board, hover the patient onto a gurney, like a little patient bed, roll that patient out, roll the other patient in, hoverboard that patient onto the treatment couch, lock the patient in. You do your minor adjustments in the room, you go out, you image, and you treat. They've increased patient throughput by 40% using this mechanism. It's really cheap. You're not buying a whole nother Linac, you're not buying a lot of stuff. You just have to have a place to set up a patient and buy this, you know, relatively inexpensive, you know, two of these inexpensive hoverboards. So I could probably introduce anyone to that company. I think that they would be willing to even do some probably pretty heavy discounts for a lot of people on this call. I think that's one other option. Just keep going, because I think throughput is so important for so many people on this call that have way too many patients probably to treat. Is treatment planning, and so being most efficient in your treatment planning. And so this could mean, instead of planning IMRT, plan VMAT. Instead of planning 4 fields, plan 2 fields where you can, 2 arcs. If you're treating palliative cases, well, can you use a conformal arc instead of, you know, a 4-field box or a 3-field with a wedges in there? Conformal arcs are really quick. So lots of areas where you can have improvement in throughput. Okay, Emily, if you could put on your list also about the hoverboard from Diacor. I think they'd be happy to work with some people on this call. It's a really cool concept.
Definitely.
And I will say I'm a big fan of standardization and protocols. I think standardization is really, really key to patient throughput. Not necessarily the same challenges that a lot of you folks might be facing, but in Canada, we do have a throughput issue as well. Huge waiting list, patients waiting months and months to be treated. And we use protocols and standardization like crazy. So the less amount of time your treatment therapist, your simulation therapist, your treatment planners are taking to do these kind of one-off special treatments, the faster it's going to be. So if, you know, 90% of your breast patients have a specific way of being set up, imaged, treated, all of that stuff, it's going to be much, much faster than if everybody has something that's a little bit quirky and different. So big fan of standardization, big fan of having as much protocol in place as you possibly can. And there's plenty of kind of little low-hanging fruit that you can introduce. I know it's sometimes a difficult conversation to have with a patient, getting changed outside of the treatment room, only uncovering the part of the body that is being treated. So, you know, breast patients really only need to change from the waist up. You can put a gown on so that you can uncover them and recover them quickly. That type of stuff. If they're getting changed in the room, oftentimes it's, you know, a bit of an ordeal for them to get their clothes all back on and get their clothes off and stuff like that and get organized. We want to kindly hustle them through the process so that we can get the next patient in, that type of stuff. And then, you know, to Adam's point in treatment planning, if you can speed that process along, there are a lot of AI tools out there that are really kind of helping to move the needle. Different treatment planning vendors have different options for contouring, whether it's Atlas-based or AI-based contouring. There are, I know, AI options for actual initial creation of a treatment plan. And if you have some folks in your physics department or your IT department that are comfortable with like programming and writing scriptings, a lot of that can really move the needle on treatment planning. Like the physicists that I've seen that can write some of these scripts, it's just incredible what they can do. And that's, you know, really low hanging fruit, and the script stuff is generally free except for the man hours to write it. So a couple of options there, and there's tons of forums online for sharing and getting ideas around that stuff. So good places to look for some added efficiency there.
And just curious, is there anyone on the call from Rwanda? While we wait for a response, it'd be great to get that person's feedback also, if there is someone on the call. So in Rwanda, I know there's a doctor from Metz, France, that is either currently working there or has been working there for a number of years. And so he took with him from, he had similar issues at his center in France, actually, where they were really struggling with patient throughput, and they just couldn't treat all the patients that they needed. So they moved to 100% VMAT for all their patients. And this was only for throughput reasons. And so again, if you're doing VMAT on all patients, then you just, basically it standardizes the workflow for therapists, and you image, you adjust, and you run your arcs, and that's it. And so in Metz, France, he was able to increase patient throughput, I think again by like 30 or 40%. I mean, they were treating 80 patients a day or something on basically standard hours. It was pretty crazy. And so they're doing that at, I think, the main radiation oncology center in Rwanda right now. So it would be really nice to hear feedback about how that's going, because I know that they're treating 100% VMAT there as well. So I do want to say that there is a caveat. And so there's a back and forth between, you know, patients that we can treat, how many, but also there are some, you know, negative issues with that too. So there are particular sites where 3D is better typically than VMAT. So things like breast patients, where you just can have a lot less low dose. So there are some breast patients, there's some chest wall patients where VMAT can be beneficial, but in general, 3D is preferable. So there is a bit of a sacrifice with the 100% VMAT approach, and there are other things to overcome, you know, QA and just planning from a physics standpoint or dosimetry standpoint. But that is another area that you could look into. And if anyone's interested, I think it would be nice if Emily and RCC can put you in touch with the team in Rwanda and get their feedback. I think that would be really cool. All right, I have not been reading the chat. Do we have more questions on here that we haven't answered?
I think we've hit most of them.
I have a question with regards to this.
Sure.
Can I go ahead?
Yeah, sure. Go ahead, Victor.
Okay. Is there any relationship between the number of patients that you treat and downtime, machine downtime. Because in our center, we have been having frequent machine downtimes, and we want to think it's because of the number of patients we see. Is there any relationship between those two? We are treating more number of patients. Could that lead to frequent machine downtime?
Yeah, the more that you use a machine, the more that you will have problems happen. But the machine issues, that's another issue that a lot of people deal with, and how do we have the most machine uptime. So that one's tricky, Victor, and I don't think I have a great solution for you. It's really complex, working with the vendor, and depending on what country you're in and availability of parts and proximity of parts. I know when I was living in Accra, it was incredibly difficult dealing with machine maintenance, and you'd have a problem, and if our on-site engineer couldn't fix it quickly with the tools on hand and the knowledge on hand, then you'd have to get an engineer to fly in from Europe just to diagnose it. And then if the predicted problem wasn't correct, then after the official in-person diagnosis, that engineer then would have to fly back, wait on a part, and then fly back once the part arrives, and then replace it. And it was a a bit of a nightmare. And I know it's not an easy solution for vendors either, and there are particular reasons why that's not easy. But I'd love to hear feedback from other members on this call, and see if they've got good workarounds that work in their center, and how are each of you on this call preventing downtime on your machines. Does anyone on this call have in-house trained engineers at your site or in your country? Do you have a stockpile of parts? Have you worked out any sort of partnership with the vendor to stockpile additional, more expensive parts and send them back on a certain time? Does anyone have any? I think it'd be really helpful if you have something that works well at your center, to be able to share it with anyone else. Or even if it doesn't work well, we can learn from that too.
Feel free to just unmute yourself. I think we have a small enough group that's okay.
Okay, and that's okay if we don't have a response. I know that's a tricky problem, and I don't. It's likely that none of us have that answer. But Victor, I think I would, if you're having machine downtime issues, it's tricky. There's money involved. So one thing that you can talk about is, making sure that people with the money to pay for these parts understand the repercussions of a machine down. And so just that understanding, I'm not saying it will fix it. I know it's not that easy, but at least having that knowledge, so whether it's controlled by your Ministry of Health, your hospital administration, knowing the difference between, okay, I've got drug X that I'm giving to a patient, and it's okay if they miss a dose or this, or but maybe there's a lack of understanding of, if we miss 2 weeks of treatment for this head and neck patient that was curative, that patient 100% is no longer curative. And making sure that the people paying for your maintenance understand this. I'm not saying it will fix it, but it could be something that if they don't understand, maybe it helps a little bit. Two, looking at, in-house training for a local engineer, and you may or you probably already have that. But talking to your engineer and seeing, you know, what are the deficiencies that he or she has? Is there additional training that could be given? Can you work with the vendor? Will the vendor be willing to supply, you know, free training for that person to really, you know, help your center? Because education is cheaper for vendors than parts, right? So you can just join a class with 10 other people that have already paid. It might be a little bit easier to get that sort of thing donated from a vendor. Chat with us if you're having troubles with it. Maybe RCC has a little bit more pull. And then are there parts that you need on site? So, you know, you should have availability of, you know, parts that wear out often. So MLC leaf motors and stuff like that, or whatever else that engineers know about that I don't know about. And can you work with your vendor to make sure that you got your necessary, you know, parts that break often on site, so you don't have to wait days and extra the cost of 2 airplane tickets and all of this. And then seeing if there are other possible workarounds for parts on site that if not used at a certain time, you can send back to the vendor before they expire, that sort of thing. But just some ideas.
We had one
Thank
last
you. Thank you.
last question in the chat. How do you answer as an RTT if patients ask about the risk of secondary malignancy from receiving radiation therapy? Maybe I would just probably route that question back to their physician. If it was me having that question come to me, I'm not sure if anybody else would have a different approach there.
Yeah, I would agree. And there is sometimes a different dynamic at a lot of URL centers. And I think we had a talk about this on one of the group chats that I was on before with on this course, that again, coming back to busyness of your centers, and depending on how busy you are and how overwhelmed each member of your staff is, that a lot of times RTTs will be taking on extra responsibilities that they might not have, you know, where I am in the United States, or where Jill is in Canada, or where Claire is in Australia. Some of you all might be facing different challenges. And so sometimes some of the burden of nursing type tasks or doctor type tasks does fall on the RTTs. So I think, you know, if you're starting to have questions, whether it's this or something else, I think, as mentioned on the previous call, it's really important to have that conversation, you know, with your physician. And so if your RTTs are going to, you know, be responsible for a lot of this, you know, patient information and patient knowledge, then have this discussion with your physicians and say, look, I need to have this information so I know how to best answer these questions. And I need to know at what point in my comfortability level do I stop and say, you know what, I just can't answer this question. I'm going to refer you to, and who's the next person in that referral process. To answer this specific question, I think the way that I would answer it is, there's a very small risk. You can discuss this risk with your physician if you want, but long story short, if you don't treat your primary tumor, you know, there's not a real worry about a secondary tumor. You have to treat this primary tumor, and this is the only way.
And I think we've hit most of the topics that we had planned on hitting in the breakout rooms, which is great. I know it was a bit of a challenge, but Adam, you did so well in making that suggestion to keep it all together. So I appreciate that.
Well,
yes,
good.
thank you so much. And thank you everybody for your flexibility without the breakout rooms. We really appreciate your patience with that.